Hello, everyone. This is Mariah Mohammed with Becker's Healthcare. Thank you so much for joining us for today's webinar, The First 24 Hours, How Novant Health and Others Are Redesigning Post-Incident Support for Our Healthcare Workers. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you are having issues with audio or visuals, just try refreshing your browser. You can also submit any technical questions into the Q&A box. We are always here to help. With that, I am pleased to introduce today's speakers. First, we have Wendy Renedo. She is a nurse leader and manager of well-being and resiliency at Novant Health, which she leads system-wide initiatives focused on supporting the psychological well-being, resilience, and real-time support of healthcare teams. With a diverse clinical background spanning ICU, education, and hospice care, Wendy brings both operational insight and bedside perspective to her work. She is passionate about creating practical support systems that help leaders and teams navigate stress, sustain purpose, and continue delivering high quality patient care. Next, we have Dr. Kimberly Johnson, is a licensed mental health counselor, educator, and clinical supervisor with more than 30 years of experience supporting individuals, healthcare professionals, first responders, and communities impacted by stress, trauma, loss, and major life transformations. She serves as director of special projects in the clinical mental health, excuse me, counseling program at Tornado University and is a proud member of the board of directors of the Emotional PPE Project. Drawing from her work following events such as September 11 attacks, Superstorm Sandy, and the COVID-19 pandemic, Dr. Johnson is passionate about advancing healthcare worker wellness, trauma-informed support, resilience, and the well-being of those who care for others. And lastly, we have Jacinta Harmon, who is the Vice President of Clinical Services at Marvin Behavioral Health and has previously served as the Director of Mental Health Outpatient Services at Penn Foundation. Thank you all for being here today, and I'll turn the floor over to Jacinta to get us started.
Thank you so much. And before we begin today, I would really like to just thank Becker's Healthcare for bringing us together and for creating opportunities to have in a conversation like we're having today. Healthcare professionals care for people through some of life's hardest moments. When they experience trauma themselves, we feel like they deserve the same level of care. And that's why we're here today, to discuss how we can better support healthcare workers after traumatic events. At Marvin Behavioral Health, we have really dedicated ourselves to ensuring that healthcare workers have access to timely, high-quality mental health support so that they can heal, recover, and continue the important work that they do every day. So I want to say thank you to both of our panelists and to Becker's and everybody else for joining us today, and I really look forward to this conversation. So let's kick it off with you, Kimberly. You have worked with thousands of healthcare professionals through the PPE Project and other initiatives. When a traumatic event occurs, what do you see as the biggest disconnect between what organizations think staff are experiencing and what they're actually experiencing?
I think one of the things that stands out really prominently for me is the idea that you're going to see a response immediately. Many healthcare workers that I've worked with, even after an initial some type of crisis on the job, that they're not showing symptoms. That's not an immediate emotional or psychological response. It might be cumulative. It might come up later, or it may be a lesser incident that causes even a greater emotional response. I think that a lot of times situations are expected to follow some type of prescribed path, and it doesn't. And for me, that's what comes up is so many of the people that I have worked with, the symptomology or what they're dealing with comes up after they're quiet, after their brain kind of quiets down, or after the event happens, or after 3 or 4 events have happened. It's nothing. It doesn't follow. It's not expected. You can't just come in and go, okay, we can debrief and move on, because it's often doesn't show up like that.
So that really brings up a great point and kind of follows up to what I was going to ask Wendy. Looking at the work that we've done together with Novant, you know, the trauma responses are incredibly personal. Two people on the same team do not experience the same exact event, and they have very different reactions. What do you think, Wendy, could account for the fact that how systems could account for the complexity of human responses rather than just assuming that everybody needs the same support?
Yeah, I think it's a great question. And piggybacking onto what Kimberly said, yeah, I feel like especially in the nursing world and with clinicians, you know, it's not that one event that usually causes a reaction. It really is that accumulation of multiple events. And that's the piece that I feel like we overlook because we assume or we make assumptions. And I think the society does as a whole, that if you went into this work, you should be expected to handle it, right? You know, you should be expected to handle a loss. If, you know, I work in hospice and, you know, that's what you do, you should just be expected. So I think part of it is taking down that barrier or that stigma and recognizing that we are people too. And so when organizations can acknowledge that and say, you know what, just because they went into this career doesn't mean they should, you know, handle these situations with no effect, right? It shouldn't affect them because they chose this profession. So I think that's one kind of institutionalized thing that we could do, or institutional thing we could do to say, like, no, it's not an expectation. You know, we need to support you through these events, regardless of the fact that you signed up for nursing or being a provider, knowing you would interact with these type of events. And then secondly, I think it's important that we train people that are going to be the responders, right? So you can have all kinds of resources available, but if you don't teach the people who are there in the moment, whether that's a leader or a peer, then you've already missed the mark, right? Because I can hand, you know, a piece of paper to someone with a plethora of resources, but in that moment, they need to have that human interaction, even if it's the explanation of the resource or the entering the phone number in their phone for them so they can check with it when they get back. And so when you train those that are actually out there, again, leaders, unofficial leaders, to do that, to have that connection, I think is really where you can make that support real and doable across large organizations.
Yeah, I'm sitting here trying to think of examples, or maybe either of you could kind of give us some on the common mistakes that leaders make, and not because they don't care, they do care, but because one, they don't know what to do, and two, they don't know what to say. So are there things that we could share with folks on the call today that leaders may say or do with good intentions, but actually just increase the distress of the folks who have, you know, had the incident occur?
Go, Wendy.
Oh, go ahead.
No, I can go, Wendy.
So for me, I get this, I have had leaders say this to me a lot. And what I always say to them is there's no right or wrong thing to say. What they need is your presence. Just dutifully be there. Be there when it happens, be there later, check in, follow up. And all of that is what people need, not the perfect thing to say or the perfect quote that you read in a book, and that's not what people need. People need you to show up. I've had leaders that I knew cared deeply for me as a team member, but they didn't know how to navigate traumatic events. So they would retreat for fear of saying something wrong. And it left all of us feeling like, wait, this doesn't match what we know she cares about us, but she's not showing up for us now. So, you know, being self-aware is the big piece of that as a leader, like being aware of what you feel too, because they're experiencing the loss or the event as well. So being aware of your own feelings and then just being present makes the biggest difference. And I think we can get so caught up in our heads of, what if I say the wrong thing? I've had leaders say to me, well, what if I cry? I'm like, then cry. It's okay. That's okay. But I think just that thought of, most of us just want support and presence from people. So do that and you're already on the right start.
Yeah. I think a lot of leaders end up being really performative because it's a safe space. It's I'll email you the EAP list, or let's have a pizza party, because things become very performative as opposed to just being very real in the moment and understanding a lot of times it's not the immediate debriefing. I mean, right in the moment, people don't necessarily need to start processing their emotions, but they need to be validated and seen and heard and acknowledged, and awareness that other things are going to come later. And it's not you go practice self-care, or you let me know what you need, which then can often re-traumatize or put the responsibility for healing back onto the individual instead of it being seen as a systemic or situation or occupational situation. Yeah. So asking those questions, being present, the peer support, so important. I mean, that's, kind of that psychological first aid moment. So.
And I think to bring this all back to our original discussion, when these traumatic events occur, everybody focuses on the team that was affected, but not really on the manager who's trying to hold everybody together, or the person, like, who's checking on the manager, who is thinking about me as the team person who has to hold everybody together, or you, Wendy, or, you, Kimberly, like who really focuses on that person, because it's a tough load to carry.
There's many structures, isn't there? There's so many layers when we talk about from directly impacted. There's still many layers out of that are impacted as well.
Yeah. Kimberly, to your work with the PPE project, what have you learned about the burden that healthcare leaders carry after traumatic events, or what have you, heard said that you think would be vital for people to know today?
Oof, that's a really good question. And it's so broad. The stories I've heard have been big. I think much of it is dealing with the own resistance or stigma around actually talking. It doesn't have to be to a mental health provider, but being able to communicate with somebody, being able to feel it's okay. It's healthcare is a profession of profession of perfection. There we go. It's that hero mentality. I can't be imperfect. I can't be human. And in many cases, you can't when you're dealing with safety and you're dealing with people's lives. There's a big burden there. And so finding spaces where it's okay to not be okay with peers and letting that be something, I think, is important. And especially for, the leaders. The leaders in these situations need to also know it's okay not to be okay. And that they have folks that they can talk to, building those support networks, building resilience programs, the things like Wendy does. I think those are invaluable for people at all levels. And I think that's what I've heard. So the wishing people would speak to them. So the healthcare workers I have dealt with wanted folks to talk. They wanted somebody to acknowledge what they'd been to. Not it's just like, oh, great, you did it, great, now keep going, or fill out this paper. And they wanted that moment to go, that wasn't normal, or that wasn't what I expected, or that hit me differently. Yeah. And have that witnessed and validated.
Yeah, I think another thing that's important to note is that when these things happen, people are handling them that really were never trained to do that. Somebody said to me last week, well, yeah, you don't respond to this because you're a trained clinician and you're trained to not be surprised at this. And it kind of made me think about the folks who are in these roles where they are holding a team together, and this unexpected event happened and they were never really trained to do anything like this.
Yeah, agreed.
Yeah, that's extremely common in the nursing world. I say all the time, we take the best bedside nurse and we make them a leader, and we don't give them any skills to lead people. And they may get like a budget class, but that might be it. So, it's been really important to us at Novant Health that we help leaders get that kind of training. So we're using stress first aid, but to give leaders that extra skill of how do I support people? Again, recognizing my own needs as well. So it starts there, like recognizing myself, but how do I support people? What does that look like? It's not just a list of resources, although that's part of it, but what does that actual support look like? And I think, we have to do better at training leaders to do that and to handle the emotional aspect that comes after, not just the event, but all the after that comes with it for themselves and for the team members. And I think we're starting to get there. I think we have a long way to go, but I do think it's getting better. I remember when I first became like a charge nurse, I just walked in one day and someone said, well, you're in charge today because you're the most senior person here. And I'm like, oh my, really? So I do think we're getting better, but we still have a long way to go with making sure that the training isn't just the logistics, isn't just the budgeting, isn't just the ERL system. It's more than that. It's the people skills too.
Yeah, agreed.
Yeah, I would say that from the work that Marvin has done with Novant, what I've learned from you about these different teams that we've supported, and what I've learned from talking to the different people on the teams, whether they be the manager of the teams or the people involved in the incident, or even the person who picked up the phone who was given the report. So there's like that secondary trauma that nobody ever pays attention to, like the person who, maybe had to deliver the news. I think that really one of the things that I've learned is that people really value being guided on what questions to ask to kind of keep them from becoming therapists in that role, or to keep them from saying something like, oh, it'll be okay, this is just a job. Like, people really appreciate having guidance around how to talk to their team members and how to check in on their team members, because they want to do that. They care. They want to be a place for people to come to.
Mm-hmm.
Yeah, and Marvin's been awesome helping us equip our leaders with those things, and supporting them, and making sure they know that the support is not just for the team, it's also for them. And it's helped me be able to give leaders, I don't want to say talking points, but just some things to think about when you've had a specific event and we've seen it before and we've seen certain people's reactions, and just given a little more prep of what it might look like when they're walking into these rooms and delivering this kind of news. But the program with Marvin and having the Caring After Crisis has been huge for a couple reasons. One is our teams do appreciate it being an external resource. We should always keep in mind stigma and what that stigma is when you get help internally. And so people have really expressed that having an external resource has been amazing. And then having that licensed therapist in the room, so facilitating that conversation, not immediate. This is, usually a week, 2 weeks, whatever later. And just being able to walk through, what did you hear? How did you feel, with the leader in the room? So, usually the leader's in the room, sometimes they're not, but, and just walking through those events, and I don't really want to call it a debriefing. I don't know what you would call it, Jacinta, but it's really a conversation of just what people felt and how they're being impacted.
Mm. Yeah. And that actually brings me to our next question for Kimberly, because you often talk about psychological first aid. Mm-hmm. So how would you say that's different than asking, these folks who are guiding these events, how do we stop them from becoming therapists? And how would you speak to psychological first aid and psychological safety?
Well, it's interesting because psychological first aid need not be done by a clinician. And that's the thing that a lot of people don't realize. It is basic training of ensuring that the individual in front of you has both mobility, the ability to keep going, and then equilibrium. There's some type of moderation. They're not like out of equilibrium emotionally or behaviorally or cognitively. And the nice thing kind of about the structure of psychological first aid, it's not about making people tell their story. It's not about anything except, do you have what you need in the moment? And the person working with them, providing the opportunity to say, what can I, be able to read the individual, where are you? Should I be more involved, less involved, listen more, guide more? and just having, and it's very much a peer support modality. It's how do I help you keep going, not so you stop what you're doing, but you can continue to do what you do in a more helpful way. And we have found with psychological first aid that it really has led to a decrease in some of the secondary kind of pathology. So we're not seeing the same PTSD outcomes or acute stress disorders or long-term moral injury issues, that we're able to maybe step in with peer support or with, allied professionals to kind of help people have that moment. And I think that's been very useful. I've seen it quite a bit in first responder work. That was a lot of what we did. And a lot of how we're looking at psychological first aid came out of what happened at Ground Zero on 9/11, and the ability to actually start to work with individuals where they are not forced the narrative. Though we do find most people, when you open the door, that story comes out and it's on their terms. And that then kind of leads into the trauma-informed component of it, which is, I'm not going to force you to tell your story. You're going to tell your story when you're ready to do it. And I think that's been really useful to kind of reduce re-traumatization and let people have their own ability to kind of take over, empower them to take over their own healing model. So,
any thoughts on this, Wendy?
Yeah, I mean, I love it. I think we've been embracing peer support through stress first aid, but very similar. And really just trying to, like, I tell my teams all the time, you're already supporting each other and doing it well, but we just want to give you a little extra help, a little extra training, a little extra knowledge, some more tools in your toolbox, to be able to identify when people are, having just a little bit of stress versus a whole lot of stress, and what that looks like for yourself and then for them. But for us, peer support is key. When you have an organization of our size, you have to have support for each other. It's the only way it works. To have 40,000 plus team members, you really do have to support one another through peer support. So I love that, Kimberly, and love all the work you're doing around it. And we're just, like I said, we're just getting started, but we're definitely headed toward that direction of getting more people trained to be able to offer peer support in a, more, I guess I don't want to say standardized, but at least common language way. So that's been really helpful.
Well, I think it also goes back to what you kind of said before, that so many of these individuals going into these situations haven't necessarily been trained how to manage the end result or psychological output. And they are. I mean, healthcare workers are first responders, period. That's how I see that. And so these kind of modalities and interventions make absolute sense to translate into the healthcare community and thinking of it the same way.
Mm-hmm.
So based on the work that you both have done and lessons learned over the years, if there's any healthcare folks listening today or any leaders listening today, are there 3 top skills that you got? I know it's a big question, or even one top skill to support staff after a traumatic event. What do you think that would be?
Oof, I don't know, Wendy.
Three's a lot. Even one.
That's a tough question. Yeah, I mean, I think, I hate to harp on it, but being present, this isn't an email or a text, this is actually showing up, being face-to-face present and continuing that presence, not assuming that just because the event's over and you were there once that it's handled. Mm-hmm. I think we've gotten, unfortunately, not very good at active listening. We tend to listen to respond. And I can, people, especially people in healthcare, are really good at seeing what the other person's thinking, and you can tell their wheels are already turning to respond to you when you're talking. So kind of learning to shut that off and just listen. I think that's something that really is helpful in these events. Those would be my top 2, I think. Kimberly, what would you add?
I think patience is a big one, not expecting things to happen on your own timetable, which is difficult when you're in a position where it's like next, and there's the next life-threatening issue. Is how do we take space to slow down, but maybe those moments, and that might be more a systemic issue than an individual leadership issue. The idea of reflective listening, much of what Wendy was talking about, the idea of being able to reflect back what the individual is saying, not assuming you're going to fill in the blanks, but kind of that ability to reflect back what the individual is saying, and also embracing and an understanding that healthcare is a culture. It is an actual culture of individuals that have a lot of shared experience, but a lot of individuality within the culture. So nurses are different, say, than physicians, that might be different than techs, which are different than the security guards that themselves. I've been having a few of those come in recently. So I think being able to look at the culture of not only the environment, but the culture of the person sitting in front of you from an occupational lens can be really valuable.
Yeah, I was going to add assumptions, because what I've learned from our work with Novant and just being a therapist throughout the year, I think the way people respond to events as well has to do with where they are at the stage in their life, you know, the experiences they've been through, whether they have young children, whether they have aging parents, whether they have children in the throes of addiction, how the event itself relates to what might be going on in their personal lives. Would everybody agree with that situation, that point?
Absolutely.
Definitely have to think of it, the individual, what their experience situated in the scope of who they are. You can go back to any systems theory and think of that person is bigger than that incident. And as you brought that up, Jacinta, what really kind of sat with me is this idea of sitting into your discomfort. I think that's a hard one for many leaders to do, is to be uncomfortable with the situation and be okay with that. Know that discomfort, this too shall pass. But being able to admit that there is discomfort, or that I might need help, or that kind of professional humility is really powerful and meaningful too.
Yeah, I thank you for saying that out loud, because we take for granted that we can be all things to all people, and sometimes we need help.
Absolutely.
So if we were to focus, maybe change focus a little bit on what actually work, lessons learned from Novant and from the PPE share. What was the moment that Novant realized that, I don't want to say good intentions were no longer, but you know, the idea or the intent, it was no longer enough. There had to be a structured approach, and that was needed, and that's how Marvin became involved.
Yeah, it's a great question, Jacinta, and I think it really bloomed from a small, well, not small, but an incident that happened when I went back to the bedside during COVID. It was sort of the impetus, and then it kind of grew as more events occurred. But I went back to critical care during COVID, and you know, everybody knows what it was like, but patient to patient to patient. There was no more debriefing, no more talking. You know, you just went boom, boom, boom. And my unit had lost a young man who'd been on our unit for quite some time. And it was, you know, of course, no visitors allowed. So I had FaceTimed his wife in, you know, small children, the whole thing. And I walked out from that room and I sat down and I just started to cry, because it was just a lot. And a young nurse was watching me from across the unit, and she walked over and she said, are we allowed to do that? And truthfully, I thought, like, am I eating at the nurse's station? Do I have an open drink? Like, what rule am I breaking? And I said, what do you mean? And she said, are we allowed to cry at work? And it hit me, like, you know, hit me hard, because I thought, you know, as a seasoned nurse, I was kind of handling my emotion in my car on my way home, maybe taking it out on my family, but it definitely wasn't processing it at work, because I was just so task driven, which we all were during COVID. And I thought, you know what, we have to do better. We have to do better, because here this new nurse thinks she has to stuff it all down. She's making an assumption that I'm a seasoned nurse and has it all together. And so we've got to do better. So that kind of sparked some thoughts. And then we had a few events that, you know, were being handled very differently, because we're a very large organization, depending on where they were. And so our well-being team just got together and said, you know, how could we look at this differently? we were already partnering with Marvin for offering one-on-one therapy for team members. And we just thought, you know what would it look like if we brought back this sort of debriefing or a place to have a response? You know, we did that before COVID and we did that internally and that went away. So what would it look like if we brought that back, even if it was virtually with Marvin? And so we just started brainstormed with Marvin and decided, you know, what it would look like and offered it to our leaders. And it just took off like wildfire, honestly. Leaders were chomping at the bit for support, you know, needing that extra support. And Jacinta can attest to this, but sometimes it would end up just being a conversation between Jacinta and the leader. It ended up not even being the full team debrief. It just was a conversation with the leader to get the leader more comfortable with the conversation with the team. And then sometimes it was multiple sessions with a team after an event, maybe a workplace violence event. And that took multiple sessions to kind of talk through and process and kind of get through the fear of what if this happens again. And so it really looks different for each team, which is my favorite part of this whole thing, is that we really let the leader who knows their team be the decider of what this should look like. So does my team, you know, I'm the leader, I know them best. Do they need a full debrief? Do they just need, you know, to talk about what the resources are? Do they need to understand what one-on-one therapy is? And then go from there. So that's kind of how it all got started and where we are now.
Wow. That's great.
Any thoughts, Kimberly?
Oh, I'm just in awe. I think that I would love to see that happen more frequently at the hospitals. I'm up in New York, and during COVID, the number of people that reached out because of the same reasons, a lot of what Wendy was talking about, of just go, 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 go. And then you go home, you sleep, you come back, you go, 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 go. I had nurses that were locked on COVID floors. I had, you know, it was a lot of just the unknown during that time. And I think the unknown was scary to everyone. I believe these kinds of supports and what you're talking about, the at least coming together for a moment of shared experience without trauma bonding, without everybody sitting into that, but as a way to kind of help build resilience and camaraderie and collaboration, which is at the root of most trauma-informed work anyway, is how do we collaborate together and have that shared moment. And I think that would be really beneficial in most environments, being able to have the guidance. And I particularly appreciate the fact, Wendy, that you shared that Jacinta would sit with the leaders at times, and it was just the leader. And sometimes that support trickles down in ways we don't think of. We often think just bottom up, or it's on you to do, but kind of in that middle range of management and leadership, I think is so important to have those spaces for guidance. And I think that could make a big difference in a lot of outcomes.
Absolutely.
I would say that what I learned from doing each of these meetings within departments, with the leaders, with the folks who are involved, is that if you think about group therapy in a clinical realm, it's the group members that heal themselves. And what I have found with Novant is that the team of people that show up for these meetings, the people who are invested in helping each other out, who are investing and finding ways to climb out of the darkness that this traumatic event brought them to, that once they all participate and know how the other folks are feeling, they really step up to help each other out and to think outside of the box in ways that they can support each other. And then that group of people really does heal each other.
Yeah.
It empowers them to be protective.
I think you're so right, Jacinta. I had a leader recently tell me after a caring after crisis event that there was about 6 team members who didn't know that each of them had lost a parent in that year.
Yeah.
And so through this other conversation, which was the loss of a patient, they ended up sharing that. And now they go out to dinner regularly and they just, you know, support each other. And they wouldn't have known that had we not done that. And so she was just sharing, you know, it was an amazing way for us to realize we're not alone. especially this was actually before Christmas and, with the holidays coming up and, it's just a lot. And so them feeling less alone by having fellow teammates, and they would not have known that had we not gotten in that shared space. And like you said, just into sort of that group work together of supporting each other.
Yeah, I mean, it normalized how they were feeling because they thought each one of them was alone in how they felt and the reaction that they were having. So I love the fact that I feel really great about the fact that they're all together outside of work and really, taking care of each other.
Yeah.
It just goes to show that we don't always know what somebody brings into an event. And that, if 80% or more of the patients that come into a healthcare setting themselves have already had pre-existing trauma, imagine how many of our own healthcare workers are coming in with their own losses and traumas and events that are going to impact the work they do, and being able to normalize it through, oh, you had that happen to you too. And that need to destigmatize or to normalize or define shared experiences is so impactful for healing and for continuing the work you do. So it's really powerful.
Yeah, you gave me goosebumps, Wendy. Thank you. So Kimberly, to stay focused on the positive and the good, because there are things that lots of people are doing that is helpful. What are you seeing that systems are doing right and that has been really helpful?
Things that I see, they're starting to talk about things such as trauma-informed language and how do you integrate that not just with your patients but with each other. How does that really come into focus? How do you think about the language and the words we use? One of the things I know we talk a lot about now is second victim issues, which I have a little bit of a problem with. I'd like it to be second survivor instead of second victim, which stays trauma informed because our healthcare workers survived through it. And I think the more, people are talking about this, it becomes a really powerful place for people to see themselves within it. So I think systems are recognizing that resilience is not a dirty word. It is not something that you do by yourself, but it can be systemic. I think that we're bringing in language into the healthcare setting that hadn't been there before. I mean, we know compassion fatigue as a term has been around, since the 90s. Thank you, oncology nursing, for bringing that into our lexicon. But it hasn't hit until maybe the last 10 or 15 years. Now we're talking moral injury in a way that's even more powerful than, we talked about through veterans, not in the way we're doing now with healthcare. So I think the fact that we're starting to talk about things, as long as they don't get weaponized or watered down, we're good. But I think that I'm seeing systems bring in peer support, wanting peer support systems, wanting to do more team building, wanting resilience programs. And those are the really powerful things I see happening within the systems around me and the people that I work with, that they're appreciative of that. It's not just cold pizza parties anymore. It's actual helping each other in a meaningful way. So, yeah.
I think we all got a little tired of the pizza parties.
It's a joke with a lot of the clients I have. Well, it wasn't a pizza party. It's a positive statement. So,
well, we do appreciate being fed, though. Like when you're on the run, trying to go from one place to another, and there's a pizza slice there, it can fill a need, right?
Yeah.
I wanted to ask both of you what you think about the idea that external support sometimes feels safer than internal resources. How do you feel about that?
I heard it. I heard a lot of it during COVID. I don't want to be on the elevator with my therapist from EAP. I don't want this. I still have clients even now that come to me that don't want to go through insurance because they don't have evidence of going through. I think there is a stigma, and the more we can talk about it and normalize it, it may make for more opportunities for people to heal. But for me, I still hear about it. I don't want to have therapy where I work. I want it to be external. I want a place that I can say anything I want to say, that I can complain all I want to complain and not be worried it gets bad.
Yeah, I mean, we see it all the time, and I understand. Like, I've even had nurses say, "I don't even want it to go through my insurance." You know, like it just really that deep of a stigma, and I think that was perpetuated a little bit by our licensure, right? Because if you went to therapy for substance use, you know, and it got reported for your license, like there was just a lot there for you to unpack. So I think it's definitely it's improving, but I do think people prefer an external resource just from that stigma alone. I always recommend both. I tell people, you know, both options, EAP and Marvin for us at Novant, and let them. I tell them, I say, try both because they're both couple of sessions are free. So try it and see which one you like. But it seems that people still have that stigma and really want to go external to the point of even paying out of pocket to not use their insurance. So
it's frequent. It's one of the Emotional PPE Project. Our board president did research looking at how the licensure applications looked and where the checkbox was compared to have you had mental health treatment? And on some it went mental health treatment, convicted of a crime. I mean, there's been this perpetuating stigma about mental health across the board for a lot of the licensing paperwork too. So you start really at the beginning of your career with this messaging. And so it's how do we break the stigma, right? How do we change the culture?
absolutely.
How do we shift?
Yes, and that has been very well needed. So I want to make sure that we leave time for questions, but one of the themes I feel like I've heard today is that support really isn't defined by whether resources exist. It's defined by whether or not people can get access to the right support at the moment that they need it. And that recovery really from these events isn't just a single conversation. It's not a debrief. It's not even a wellness initiative. It's a process. The organizations that do well with this aren't waiting for people to ask for help, but they've built systems. They've built systems that know how to respond and when help is needed the most. Does that seem like a fair statement?
Absolutely.
Yeah, I completely agree. I can't tell you the number of times that I've put resources in front of someone and they didn't hear a word of it until the next day, and they call and say, I know you gave me something. I know you talked to me about something, but can you go over it again? So that's why a lot of times I'll be like, can I put it in your phone now? That way you'll have it, you know, or I'll email it. And it really takes that follow up because I feel like in the moment, it's just so much information overload, information processing, still processing the event. And so it really does take that continual follow up reminder of what's available, how to get to it. It has to be easy. If it's 15 clicks, you lost them at 2. And so, you know, it has to be QR code or something extremely easy to get people enrolled, user friendly. You know, Marvin has where you can kind of help dictate who you want to meet with, and people love that. So you have to meet people where they are. And after these critical event moments, handing them a page of resources, isn't it?
I so appreciate that you said that. That is the one moment that's the worst time to hand people most information, right? Because you're already overloaded. Your brain's not processing anything. A lot of people are numb, slightly dissociated. They're just surviving. And so if you're like, okay, now do all this, they're like, I'm sorry, what? So I love the follow-up. I love the idea of access and consistency of outreach. So yeah, appreciate that.
Well, I appreciate both of you and the insights you've given us today. I wanted to leave time for Q&A, so we can go ahead with that if that would work for everybody on the call.
Yes. Yeah, that sounds amazing. Thank you to all of you for a wonderful discussion today. As stated, we will now begin the Q&A portion. Again, audience, please feel free to submit any questions that you have via the Q&A box you see on your screen. I know we have a lot of questions already submitted, so that is wonderful. So we could go ahead and get started. So ladies, the first question that I have for you is, one of the biggest challenges I face in my context is that shift change often takes the staff involved in a critical incident and spreads them to the winds. What's the best way to follow up when an in-person diffusing um, debriefing is not possible?
Hmm.
So we try to offer a couple different options. One is we can pull people together virtually, which we do with Marvin through Caring After Crisis. So if we, send the invite, people can join if they'd like to. And then a lot of times we'll just ask if they want to come back in. Now, I'll be honest, most people don't want to come back in. So they prefer to do it virtually from, the comfort of their own home. But I think, doing that and at least offering it helps. If people are willing to stay over, I think that's great. Some people I have found are still milling around after an incident, like they just can't quite go home yet. And so if you can grab them in those moments, I think that's ideal, but definitely offering a virtual option or later on in-person offering. I think the other kind of misnomer is that you have to do it right away, like immediately. Mm-hmm. And I do think there needs to be support immediately, but I don't think it has to be the whole coordinated support immediately. Oftentimes that takes time to get scheduled and let people kind of process some of their emotions. So a lot of times that immediate support is just simply support. And then the later is the actual processing of emotions, talking through things. And that's when we often, bring in Marvin for that.
Yeah.
Wonderful.
Makes sense to me. I also really like the idea of waiting. I don't think that trying to process things in the moment is always the most helpful for anybody. And so the idea of the stabilization and then moving into maybe the next shift, having that opportunity to have that come together, it can give people time to know where they are as long as people are stable leaving.
Yeah, and I would say that one of the things that we found with Novant is that having that 24/7 crisis line available for folks to call on their own time, in their own moment, when they go home at nighttime and they can't sleep and they just need somebody to talk to, that has proven to be really a vital resource for all the systems that we work for, but especially people. It helps to mitigate the negative impact if when something happens at work. I agree that when something happens, there's so many emotions raging, and that people need to settle down just a little bit to figure out where they actually sit with what happened and how it's impacting them and why. And so having a crisis line support where it's a therapist who answers, not necessarily to do therapy, but just to kind of debrief the incident and again, normalize and validate how people are feeling in that moment has been really impactful for the systems that we work with.
I didn't know you did that. That's so cool. Sorry.
Yes.
I just had to fangirl a moment. That was really neat.
Thank you.
Wonderful. Yeah, that definitely all sounds very helpful. And then another audience member said, how do you address the clinical fear or clinician fear of, is this truly confidential, or will talking to someone risk my license, especially when you think about cases with mistakes or professional faults?
Well, I know for me as a clinician, I have ethical codes that I'm pretty strict with, that that breaking confidentiality is not really an option for me. I think in peer support, it looks a little differently. Maybe Wendy, you could speak to what that looks like for confidentiality side.
Sure. So first, I always reiterate to them that if they choose to speak with a therapist, 100% confidential, same thing Kimberly just said. As a peer, if they choose peer support, usually what I tell them up front, number one, is I'm not a therapist. I'm a nurse who's been doing this a very long time, and that's where I'm here to support you. And then I do not talk about the actual event. So the patient details, what occurred, like, I gave a wrong med. Like, I want to talk about how you feel, not the actual event. So that's the piece I try to, and if it gets steered back to the event, then I just steer it back to the emotion. Because I don't have confidentiality protection. So I just make sure I tell them that up front, and then try to make sure they understand, like, I'm here to support you as a nurse who's also, of course, been through a lot. And I can't talk about the actual situation that occurred, but we can talk about how it's impacting you, how you're feeling, what you're taking home, that kind of thing.
And I would say that's why Marvin appeals to most of the organizations that we work with, is the fact that we are outside of their system, is the fact that our EHR is not part of their system, and the fact that, we are licensed therapists, and so we cannot break confidentiality. So that's a given.
Yeah, yeah, absolutely. And then I think the next question that I have, a little more broader, what should leaders expect from a specialized partner in the first few months after an incident? And what should still be happening in the days and the weeks after?
I'm not, I'm not sure I understand specialized partner. You mean like our partnership with Marvin or a
Yes, I
peer
believe
support? What?
so. Mm-hmm.
Oh, okay. Yeah. So with our partnership with Marvin, if we start a caring after crisis event, there's like I said, it's really driven by the partnership with Jacinta's team and the leader. So they meet and discuss what the team needs, and from there it can be anything from immediate support within the next couple of weeks. It could be, hey, we need to look out a couple of months. We've had teams that, I think, was it 6 months, Jacinta, that you ended up meeting with that team, every few months?
Every 6 months, yeah, every six. So it was immediate,
Yeah.
and then there was 3 months, and then the next one was 6 months, and the 6 month was just a check-in to see how everybody was doing, because as we mentioned earlier, you're not sure who's going to react when and what they find is happening in their own lives that will impact them.
Yeah, so it's really not a blanket response as far as after every event you get X, Y, Z. It really is meant to be driven by what that team needs. And Jacinta and the leader and myself just work together to, figure out what that is and make sure those needs are met.
Got it. Perfect. Thank you so much. And then another question that we have, audience members, please feel free to keep submitting your questions. How do you overcome the resistance, especially in leadership who may have grown careers in environments that didn't have support like this and, quote, turned out just fine?
Yeah, that's common. I think so. I've been a nurse, 26 years now. And I was trained, leave everything at the door. When you enter these doors, your focus is the patient. And there's still a lot of people that really believe that. And that honestly is not how we live. It's not how we function as human beings. So it's very unrealistic to ask someone who, like myself, has a special needs child at home who may need me at any moment to just drop everything for 12 hours. And meaning drop it off my heart. Like, I'm still thinking about him. I'm still worrying about him. So I think it really takes a change of culture, really at the organizational level, to say, we support people throughout their entire journey. We meet them where they are. We don't expect them to just pretend their life doesn't exist outside of work. We know that that is a huge part of who they are. And, that's also what helps people feel like they belong at organizations. So I think it really takes a change of culture to say, yes, we all, like, I survived. I'm here. I'm still a nurse. But I could have done a lot better further back in my career if I'd had the support that I have now. I'm grateful that I have it now, but if I had had it 26 years ago, I might not have, pushed my family away at certain times, or, burned my body out because I was working 5/12s a week, so that kind of thing. So I think it really does take a change of culture.
Agreed.
Any thoughts on that, Kimberly?
I think that was well stated. I think it is a change of culture. It's the idea of I came out okay is not a measurement tool. It is not just because it was easy for me. And as a clinician, we were told we left ourselves outside the clinical space. We were empty vessels. We now know that's impossible to do. and we just learn how to manage it. And so I think that, for a system that's used to things as status quo, we know the status quo changes. You just like you have, new medical procedures, we have new ways of thinking, and it's okay to start thinking that way. And just making it through may not be what we want. We want people to stay with the job. We don't want to be losing, our practitioners because they're burning out, because they're, going through compassion fatigue, because they're overwhelmed or stressed. So I agree. I think we do need to really consider this as a change in culture, that it's okay to have these conversations now.
I think gone are the days when we expect people to just pretend on. People might say that they're fine, but are they really? And what have they done with this, and where have they put it, and how has it impacted the rest of their lives? And are they fundamentally changed because of this event, and because they just pretended on, then they're just fine, and they'll just keep motoring on. And so I really appreciate that question, because there are times when we feel that everything turned out fine, but I'm not sure that it did.
Yeah. Fine becomes a dirty word sometimes. How are you doing? Fine. Yeah.
Yeah. And I think the other thing is, with healthcare workers, we do show up fine at work, right? We're great at work, and people don't know that we're functioning at like a 2% battery. It's the people in our home lives that suffer from it. They're the ones that we fall asleep during dinner, or we don't go to the movie because we're too exhausted from work. And so, realizing that you want your employees, you want your team members to have a full life, not just at work, but at home too, is where, well-being and support really comes in. Because if they're burning out and their family's suffering, eventually they're going to choose one or the other. They're going to have to. You don't want that. I'd never want a team member to have to say, oh, I have to choose between work and home because I can't do both.
Agreed. Well said.
All right. Well, I want to say thank you very much to both of you today for your time. I see that we're almost there. If anybody has any interest in learning about our Caring After Crisis program, please feel free to reach out and ask. And to both of you who took the time today to share your insights and expertise, we truly appreciate the difference that you made today. Thank you.
Thank you for the invitation.
Yeah, absolutely. Thank all three of you, honestly, for a wonderful discussion. And audience members, I know we have a lot of questions that went unanswered for all three of them. But they will be reaching out afterwards. They'll be sent these questions. So you definitely can contact them, or they will contact you with some answers afterwards. But unfortunately, that is all the time we have for today. So again, I do want to thank all three of you for coming to speak and for an excellent presentation, as well as Marvin Behavioral Health for sponsoring today's webinar. Thank you again for joining us today, and we hope you have a wonderful rest of your day. Thank you again.
Thanks.
You.
Take care.